Welcome to this module in which we'll be conducting an overview of quantitative study designs. After completing this module, you should be able to complete the following learning outcomes, which include being able to identify, describe and differentiate between the various quantitative designs, evaluate the advantages and disadvantages, and then hopefully apply your knowledge of quantitative research designs and methods in the context of public health evaluation. So the first type of quantitative design that we're going to talk about is a case study or report. So as the name suggests, is really a report on a single patient by a health professional or group of health professionals. Most commonly they focus on one patient reporting a rare outcome or an adverse event or a particularly rare symptom. They can be, I guess, pulled together to form what we call a case series, which is basically a report on a series of patients with the same outcome of interest. The one thing to really note with a case report or a case series is that there is no comparison group. In reality, we don't use a case study I guess in health promotion and public health evaluation all that often when it relates to a single person, but we can use the case study approach when we're looking at a single organisation, so to speak. So rather than looking at a patient, we may be looking at the organisation, which may be a hospital, for example. So the classic example of a case study is something like the Elephant Man, which would be highlighted as an example here. Very, very unique study, very, very unique circumstances and symptoms, and something that can be studied as a case report. Highlighting its uniqueness and its rarity, it was able then to raise awareness about that particular condition of interest. Our next method that we're going to look at is a cross-sectional study, which can also sometimes be known as a prevalence study. So the thing to identify here is that cross-sectional studies focus on individuals, and they're basically looking at measuring the prevalence of a disease or the presence or an absence of a particular exposure. As the name suggests, it's a cross-section, so it's just looking at participants at one point in time. So it's not directional in the sense that it's not looking forward in time, nor is it retrospective looking backwards in time. It's just looking at this point in time at November 30, whatever year that we are in, what is the prevalence of this particular condition or issue. So here we have an example of that, looking at a cross-sectional survey or questionnaire that was conducted in men and women with mental health issues, and seeing who of them would seek help from a GP regarding their mental health problems. And it's very neatly broken down in terms of the participants, so whether they be female or male, their answer to the particular question, so yes, I would seek help, maybe, or no, I would not seek help from a GP. And what's really neat about it is it's then been able to break down the data according to various categories. So men aged 16 to 24, 55 to 64, and overall, and similarly for the females. And what's really interesting when you look at the data, just as a side note, not much difference between the yes and the no's between males and females, although what is interesting is this reluctance to go seek help from males in their early years, so to speak, so 16 to 24, which is not surprising given what we know now, but when this particular study was done in 2005 was particularly groundbreaking. So a variant on the cross-sectional survey is an ecological or correlation survey. So very much an extension of the cross-sectional study, except the units of analysis here are populations or groups rather than individuals. And so this particular type of methodology can be used a couple of ways, whether it be looking at different populations during the same period, or looking at the same population but at different time points, longitudinally speaking. So here's an example of a prevalence study where it's grouped participants according to regions. So whether it be Asia, Africa, it's clumped everyone together as the world population, Latin America and Caribbean, Oceania, North America and Europe. And this particular correlation study is looking at the prevalence of obesity in adults. So we've got the percentages along here, and then we've got time frames along here. So it's looking at, I guess, the same population but across different time points. And what's really interesting to note is that pretty much all populations are trending similarly, despite the fact that they've started at different points, I guess, in the first instance. What's really interesting to note is that Oceania here, we're quickly approaching North America and Europe in terms of prevalence of obesity. So now we come into, I guess, some trickier study designs. And the first one, which is commonly used in clinical research, not so much in health promotion and public health evaluation, but it's still useful to know. And that's what we call a case control study. So it compares the occurrence of a possible cause of a disease or outcome across what we call patients that are cases and those that are controls. So data is collected at one point in time, but what we're looking to do is retrospectively identify who was exposed to this particular risk factor. Pretty difficult to get your head around, so I'll use the next slide to try and explain it a little bit better in a graphical format. So here we have our case control study. Time is moving forward, and we've got our population of interest. So typically what we're doing with a case control study is retrospectively trying to identify what may have influenced people either getting the disease or getting the desired outcome of interest compared to those that did not. So in doing so, we need to firstly identify our cases, so people with the disease. So you may think of people, for example, with cancer, as opposed to our controls. So same group of participants in terms of demographics, so age, sex, any other comorbidities. The only difference between our cases and our controls is our controls don't have the outcome of interest. So in this case, it may be cancer. So like I said, typically these types of case control studies are used in clinical research, but we can also use them in public health evaluation. Rather than looking at cases being a negative, we can look at a positive outcome. So our cases may be people who decided to get screened for colorectal cancer, and our controls may be those people that did not. And what we want to identify is why do those people who did get screened for colorectal cancer, why did they, as opposed to those that did not? So in doing so, we want to identify what each group was either exposed to or not exposed to. So if we're looking at from a clinical point of view, we may be looking at cancer, and we may identify, well, all our cases, the overwhelming majority, were exposed to a particular risk factor, and only a small population here were not. Similarly, we do the same for our controls, and we might identify that only a very small amount of participants who were identified as controls were not exposed to the risk factor, were exposed to the risk factor, as opposed to the overwhelming majority who were not exposed. So that's looking at it from a clinical point of view, but from a public health point of view, like I said, we may be looking at cases here representing those people that did get screened for colorectal cancer as opposed to our controls here who did not. So by conducting interviews, surveys, etc., we might identify that the majority of those who did get screened for colorectal cancer did take up the opportunity to use the FOBT or fecal occult blood test that's that's posted to people aged over 50 years of age in Australia. Conversely, those controls who did not get screened for colorectal cancer, we might identify that the overwhelming majority decided not to take up the opportunity to take the FOBT that was posted out to them. So here we go. We've got an example of FOBT testing on mortality from colorectal cancer, a case control study. So this is, I guess, looking at it from a clinical point of view, seeing who did and who did not get screened for colorectal cancer in terms of the FOBT. So here we have our next, I guess, batch of quantitative study designs are cohort studies. So very much as the name suggests, cohort studies take a cohort and basically follow it up in time to see what happened to them in terms of the outcome. So it's very much an observational type of study design where we separate groups from within the cohort to those that were exposed or not exposed to a particular risk factor or activity or whatnot. So not to be confused with a case control, which looks backwards in time. Our cohort studies are prospective in terms of their design. So here we have a graphical representation of a cohort study. We're moving forwards in time, and our direction of inquiry is also prospective. So we have our population of interest. From that, we take a particular sample, and then we identify those that were exposed to the intervention or risk factor or activity or whatnot, and those that were not. And so those that were not, we label either as our controls or our comparisons if they undertook a different intervention or activity. And then we simply follow them forward in time to identify whether or not an outcome is either present or not present. So very much a simple design, but a very powerful design as well. One of the limitations, I guess, associated with the cohort study is the fact that they do take quite a number of years to implement in terms of the follow-up period. Conversely, the case control study can be conducted over a very short period of time. So 6 months to a year, because all of the outcomes that you're interested in have already occurred, and what you're merely looking to do with a case control study is identify who was exposed to what. So here we have a particular example of a cohort study. So from a health promotion point of view, it was looking at whether or not a football-based program could increase children's, I guess, knowledge and awareness and attitudes towards health education and health awareness. So it had the one cohort in terms of children, and then they chose to either engage in this particular football-based program or not engage. And then from there, they were able to identify what the outcomes of interest were in terms of increases in knowledge, awareness, etc. So the final type of study design that we're interested in is the randomized controlled trial, which I think everyone has heard of. So very much similar to our cohort study. The only difference being is that people are randomized to either the intervention group or the control or comparison group. Again, majority of times randomized controlled trials are based on individuals, but we can have variations on a randomized controlled trial where we randomize not individuals but groups of individuals, in which case we call it a cluster randomized controlled trial. Excuse me. So here we have a randomized controlled trial. We're moving forward in time and the direction of inquiry is also prospective. We have our population and we may take a sample of those people or participants from a population. In this case, there may be patients with osteoarthritis, and we randomize them either to one group or another. So randomly allocated to either receive the intervention, which in this case we've gone with glucosamine, or the placebo, in which case this is the control group. So our study for this particular trial is trying to identify whether or not glucosamine has an impact in terms of reducing pain in patients with osteoarthritis. So as you can see, randomized controlled trials are fairly common or very common in the clinical world. A lot of the time when it comes to drug trials, we can do the classic placebo randomized controlled trial where one group gets the intervention and another group gets a placebo. So one group gets the glucosamine tablet and another group gets the placebo tablet, which looks the same, tastes the same as the glucosamine, but obviously doesn't have the active ingredient. Where randomized controlled trials, I guess, fall down a little bit is with more pragmatic interventions. So something like acupuncture. Trying to create a placebo acupuncture can be quite difficult. Although, if you read this particular study, they've been successful in randomizing people to the intervention, which is acupuncture, but then also creating a placebo version or a comparator, which is a sham acupuncture. So again, you have to be very creative in terms of ensuring that people can't tell whether or not they've been allocated to the intervention or the control groups. Here's another example of a randomized controlled trial. This is looking at physical-based activity and whether or not or how much of an impact it has. And so what you can do with these types of studies is not necessarily have a placebo group, but have one group which has the intervention, and then another group which also has the intervention plus an additional aspect to it. So in this particular case, both groups may have had physical activity, but one particular group had the addition of having social media intervention associated with it. So both groups had a physical activity program, but the intervention group had on top of the physical activity program social media support, so whether it be through websites, Facebook, Twitter, etc. And so I won't go through the results of this particular study, but it seemed fairly successful. So that's our little presentation on quantitative study designs. What I will end up on is this pyramid that we call the evidence pyramid. So why do we call it the evidence pyramid? So up the top here, sit our randomized controlled trials. And then as we progress down the list, so too do we see our cohort, case control, case series, and then opinions and ideas. The reason that we place randomized controlled trials up the top is that they're very robust in their design. So the fact that we're randomizing people to one group or another means that we're got a fairly similar population that we're testing across both groups. Similar in terms of numbers that we're placing across groups, the types of biases associated with it, the types of comorbidities that they may have should be equally distributed between the intervention and control groups because we're randomizing people or groups or organizations to these groups. Because we don't have a randomization procedure in place for cohort studies, case control studies, and certainly for case series and cross-sectional studies, they're placed down, the pyramid because they inherently attract other biases associated with their design. Things like confounding, so the influence of other factors into the methodology itself may impact upon the outcomes. Now, while ideally we'd love to do randomized controlled trials for all types of public health evaluations, pragmatically, it's not going to be possible. So there's always, I guess, the thing that we have to account for is balancing between what we'd like to do and what's pragmatic. So yes, I'd love to do a randomized controlled trial of a physical education program, but in reality, it's probably not going to happen because I can't really expect to randomize one group to do training 3 times a week and the other group to sit on the couch, because it may not be ethically or morally right to do so, but more so those people that have been assigned to the placebo group or the control group will soon realise that they're not doing exercise and probably drop out of the study altogether. So in which case, something like that, we may turn to a cohort study, which may be more pragmatic. That is, getting a bunch of people together and then providing them with the opportunity to participate in an exercise program, and those that do participate in it, those that don't serve as our control group, and then we follow both groups up forward in time. Hopefully that's been of value, and hopefully it's provided you with a nice overview of quantitative study designs.